Hello, today we are going to talk about the use of CT angiography and perfusion in the evaluation and treatment of acute ischemic stroke patients, addressing both standards and potential pitfalls. My name is Edward Sloan. I work with fern.org. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois. I also am Medical Director for New Rose Healthcare Management, helping the emergency department at Roseland Community Hospital in Chicago, a safety net hospital. And I serve as Medical Director for the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This information is being presented at the Clinical Decision Making in Emergency Medicine meeting, June of this year. I want to give my thanks to Joan Esbrey-Cullen, Andy Godwin, Andy Jagoda, Ginia Ports, and Scott Silvers, with whom I've worked at this good meeting for several years. I have no financial conflicts. I serve as the Fern President and Board Chair. Two last things to consider. Chris Lewandowski, a colleague of mine and good friend, provided some commentary. Here's what he said regarding this whole issue of using CTA and especially CTP in determining which patients get which therapies for acute ischemic stroke. He said for sure non-contrast CT and IV thrombolysis is surely in the emergency medicine domain. He stated that the information gained on CTP about cerebral blood flow and the size of the penumbral tissue does guide treatment, but it has some limitations. He identified that there are patients with good collaterals who slowly progress from ischemic penumbra to infarct, and those who have poor collaterals who quickly progress and have less salvage because the ischemic penumbra becomes infarcted tissue quickly. He did demonstrate that suggest that MR DWI is a bit more sensitive than CT perfusion for measuring a mismatch in small strokes and posterior strokes and should be used in these unusual presentations. And he talked about the issue of using DWI and FLAIR because it helps to time the stroke patient as having an early stroke, in which case IV thrombolytic therapy may still be useful. Dr. Lewandowski also referred me to the ENDOLOW study, which is looking at the utility of endovascular therapies for patients who have a low NIHSS stroke scale less than 5 and who may or may not have a demonstrated LVO. He stated that there's no significant data regarding MR microhemorrhage determination, therefore a non-contrast CT is okay. He said there are low Tesla portable MR machines that could provide DWI and FLAIR information, which could improve our ability to determine the need for EVT therapies in the ED. He said on CTP there are noted now He noted that on CTP there are noted gradations of how much hypo-perfusion there is in the ischemic penumbra, and this may help in determining which of these patients with a large ischemic penumbra should go for EVT. And he stated that the volume of the core infarct does influence the utility of EVT using about a 70 cc cutoff. Those with larger core infarcts probably will not benefit from these therapies acutely and or at 3 months. And the last commentary comes from Andy Asimos, who has been working in North Carolina extensively looking at the use of this multimodal CT testing in patients with acute ischemic stroke. He said CTP does provide benefit, and he says he reads dozens of these tests a day. He stated that a negative CTP does not necessarily mean the patient is not having a stroke. He does understand that some patients with stroke mimics will receive thrombolytic therapy, but that it happens less frequently if you do CTP or DWI imaging. He noted that MR DWI, as with Dr. Lewandowski, is more sensitive than CTP for small posterior strokes and if a mimic is suspected, and so should be utilized in those cases. And again, he echoed that the MR DWI FLAIR situation can identify the stroke patient as having an early stroke, therefore IV thrombolytic therapy may be of benefit. He did recognize that most MRAs are done without gadolinium. There's no contrast needed to measure the flow. He said in the future, CTP AI applications will tie a clinical prediction score to the actual CTP data, generating a stroke probability score and the potential for benefit by using extended EVT therapies. But he said generally this kind of technology where you could predict prospectively is not yet ready for prime time, and that neuroimaging workflow is not in the emergency department scope of practice. But he states that if this information is understood by emergency medicine providers, and that by hearing this information, such as the use of the aspect score and the general idea of what is trying to be done, that it is possible for the emergency care provider to aggressively move to get patients who may benefit from EVT to that therapy or transfer to a comprehensive stroke center for that therapy. Thank you for your time in learning more about optimizing the care of patients who present to the emergency department with acute ischemic stroke. You can scan this QR code to find out more about our social media links, and you can send me a question to fern.org@gmail.com or edsloanmd@gmail.com. Once again, thank you for your participation in this Fern educational effort. Have a good day.